Hey guys, Don here. Welcome to the $1 Million Minute. Just kind of helping you get your practice to the $1 million mark and beyond. I'm going to go over, this was one of my days. I had 20 patients. I had 2 open slots, so I usually see about 22 patients a day. And I'm going to go first over my most valuable patient. My most valuable patient, this was a patient that was on a third opinion. She had insertional Achilles tendonitis bilaterally. She had been seen by a chiropractor who did Shockwave on her, and also by a physical therapist that did EPAT, which is radial shockwave, and she didn't get better with either of them. She's kind of struggling with this foot pain. Today I did, this is the second visit. The first visit I kind of went over some things with her, did an ultrasound, showed her the thickness of the Achilles and the areas of the pain at the insertion, which I find tends to work better with focused shockwave. And so what I did for her is I did 3 sessions, or I'm going to be doing 3 sessions of bilateral combo. Combo is radial and focused shockwave. So, and then she tended to prepay, so that it's about $1,500 for those 3 sessions because it's bilateral. And then if they pay that up front, I give them a 10% discount. So if they prepay for everything, it kind of makes them do all the treatments, but I also think gives them a little break if they want to do that. So that was the MVP patient of the day, and I think there was a kind of a second MVP patient. This was kind of interesting. This was a patient. She's a nurse practitioner, and she works kind of in wellness. She has a painful bunion. And she has a bunion bilaterally, but the one on the right is more painful. She's not really wanting to do surgery. She's already wearing anatomic shoes. She's wearing toe pose, but she has this pain in the joint. She can't do her yoga poses, things like that. She has a little bit of arthritic spurring on the side of the joint, but really still has good joint space. And so what do you do with this? You have options of doing like correctos. You have options of cortisone injection, icing, anti-inflammatory. She's been taking turmeric. So for this patient, I'm going to do 4 sessions of focused shockwave. So focused can help with the bone marrow edema. Many times that's around the joint. It's not going to take away the arthritis, but I'm hoping it's going to make her joint feel better and get down some of the swelling around the joint that's painful for her. So this was the second MVP. So those 4 shockwave sessions, we're gonna set those up for her. Also, just because she's another kind of referring provider. Okay, let's get back into the day here. There was a patient that came in. He's already had 3 sessions of shockwave on the second med head. Continues to have pain, and I'm going to order an MRI just because I'm not sure kind of what else, and he's kind of looking at fixing the hammer toe and possibly pinning it to help repair that area of the metatarsal plantar plate area. But he also has symptoms similar to a neuroma in that area as well, and we are going to do an MRI to kind of see what's going on. He also ended up having some tinea pedis to the front of the foot, pustular tinea pedis that was almost like blistering, so it was painful. So I did prescribe him a topical, and I also gave him an oral for a month. So that brought the office visit up to a level 4, and then we'll do the MRI. Other patient that came in that is having pain, she has been having pain for 6 months. She twisted over a root in a flip-flop, kind of had a plantar flexury injury, possible Lisfranc, so I ordered an MRI for her as well. She has some gapping between the first and the second met bases. So that was another patient that we had. Another patient that came in. She had a fall, just got a whole bunch of x-rays, nothing was really done. I had my patient, this is the patient you probably heard of, we've been talking about him for a couple of weeks now. He's an EPAT number 3. He had an amnio last week due to like a 5th met bursa, and he is responding very, very well at EPAT number 3 for him. So he is doing very, very well, getting better, and he's very pleased with the results. Patient with a partial nail avulsion, another patient with EPAT number 3, another patient with an IND, another patient, this had a bilateral plantar fascial EPAT. This is number 3, so I'm going to see her back in 2 months. Another patient for an IND, a patient with hallux limitus that came in, new patient, and because of the hallux limitus, we went over all the biomechanics of it, and we did orthotic. That was one of my orthotic number 1 for the day. So my goal is I try to get 2 orthotics per day. Other patient came in, she had a hammer toe. We spent a lot of time talking about shoes. A couple of resources that I give my patients. Locally, there's a place that sells Topos and Ultras, which are our favorite kind of running shoes. Then we carry LEMS in our office, LEMS, if you haven't heard of that. And then the most common resource I send my patients is to Anya's Reviews. It's a good review for female patients with like cute shoes that are anatomically correct for them as well. So she's going to be trying the anatomic shoes, and I think that's really going to help her little hammer toe. She just had a fifth hammer toe. I think her shoes were just not enough stretch in them. Other patient that came in, she's for a follow-up with plantar fasciitis, and we talked to her today about reducing the strain on the fascia. I did a quick little ultrasound, but she's feeling much better after her treatments of her Shockwave, and we talked about doing an orthotic to offload the fascia. So the way I kind of explain it with orthotics, and I learned this from Larry Hupman, is that orthotics, if you high contouring orthotic, it takes the strain off of the fascia. So it's going to make the fascia feel better by pulling less on it. And so that was the rationale for it. She is kind of considering if she wants to do that. Now, when patients want to consider orthotics, I would prefer them not to come back and take up a time slot, because it's all about reducing these low value patients. So you're like, oh, but it's an orthotic, it's a high value. Yes, but they don't really need to see me to do that. So if the patient wants to come back and get orthotics, many times I'll have them make a medical assistant appointment just to not take up one of my spots. Or in this case, what I did is I scanned her for the orthotics, and they're just not ordered until she makes payment. So if she decides she wants them, which I recommended, then she'll just call the office and get them. So just a way of kind of saving visits, so saving follow-ups. As I mentioned before, I always try to have patients either not come back if they don't need to, or reduce the follow-ups with me, so I can use those slots that I have for more valuable patients. Another patient that came in had she was using correctos. She had a porokeratoma. I treated that with lesion destruction, and I gave her my shoe recommendations. A lot of times I spend giving shoe recommendations. Another patient came back for a second visit, has pain all along the peroneals, and tried foam rolling, got a little bit better, but due to this pain that really is at the fibular head all the way down, I'm going to do 3 sessions of Shockwave, kind of all along the peroneals. And she's going to set up those 3 sessions. I did not do it today just because she had taken some anti-inflammatories a couple of days ago. Also, a patient came back. I did a cortisone injection to a retrocalcaneal bursa. She had a kind of a bursa posterior, or I guess deep to the Achilles, and she responded very well. I don't do a lot of cortisones back there because of the Achilles, but I put her in a boot, and she is about 70% better. And I'm going to see her in 2 months to see how she's doing. Potentially, if she still has some tenderness, then I would add some Shockwave. I like to do 2 months because it'll get the cortisone out of the system, and then at that time she would be a candidate for Shockwave if needed. Also, there's a patient second visit after Severs and doing orthotics, feeling much better. They did want some physical therapy, so we added physical therapy. This is a little 10-year-old boy. Another patient that came in for multiple porokeratomas on the plantar foot. She had like less than 14, like 12 of them. This is something that I see pretty common for patients that go barefoot quite a bit on hardwood surfaces. And specifically, I'm not sure why, but certain cultures, in this case, I just see a lot with Indian patients. I'm not sure why, maybe just because they go barefoot a lot, but they have a lot of porokeratomas, or maybe because they're skinnier and there's just less padding down there. But I took those down. I did some salicylic acid with lesion destruction. I did consider, I've heard some people use Swift for this. I did not do it. I just did the lesion destruction initially. I guess potentially I could have used Swift for this patient. I just don't have a great belief in Swift for porokeratomas, but I've heard that they do that. Maybe if I did it for free to try it a couple of times, maybe it would increase my belief, so maybe I should do it a couple of times for free just to make sure it works. I struggle with that. So things that I don't believe in, or I don't trust that it'll work, I have a hard time offering it, which makes sense, right? Because I don't want to have that conversation afterwards. Sorry, you dropped, 4 Swifts can be $1,000. Sorry, you spent $1,000 with me, and you're not better. So that's just kind of my mindset. And then the other patient was a EPAT number 3 with a 2-month follow-up. So anyway, that was the day. Things that are kind of on my mind. This is a day back after a holiday. We are planning for our EMR transition, which is going to kind of be a while from now. And I was thinking, this whole idea of kind of sharing what I do, this is something I think would help you if you're trying to get to $1 million mark in your production. And I think what is tracked gets better. So the way I do it is I just basically print out my day sheet, and I put the level of the visit on the left side. I put, if I did x-rays, on the upper left corner, follow-up on the lower left corner, and then on right next to the office visit level, I put what I'm seeing and kind of what I do, like as DME or things like that. So if you're not doing this might help you. The challenge with doing this, in my opinion, is before I had a scribe, I really didn't have time. I was just like so out straight doing this. So I think a lot of times what hinders us is we're out straight seeing patients and we don't have time to do these other things that would help our practice get better. And then another thing I'm kind of struggling with, these are my daily rants, is I want to focus more on orthotics and improving orthotics. So right now I do about 20 orthotics per month. I would like to get that to like 40 or 50. I know a few people that do that. And I think one of the things that would help me to do that would be shadowing other people that do more orthotics. But the struggle I have, probably with the same struggle that you have, is then deciding, like, okay, do I take a day out of my practice to go visit someone to see how they do orthotics? Or do I, kind of just keep treading water? I think one of the thoughts is, as I'm finishing up this year, kind of looking at my numbers and see, okay, well, in a typical month, let's say if I typically want to work, let's say 20 days, right? So there's 4 weeks, so 5 days a week, so 20 days. And then if there's certain months where maybe I'm working 22 or maybe it's 18 days, just figure out how many days. And so on months that I'm not working that many days, I could actually take a day off to shadow someone, to travel somewhere, to learn something else. Because I think this whole learning aspect is what really is needed versus even going to like a CME course. I find CME courses they're helpful a little bit, but I get much more from visiting another doctor. And that's why I also have people come and visit me in my office, because I think, I like to go visit others to learn. I would like people to come visit me. But I think objectively, if I could have that in my armamentarium where I'd look, okay, this month I worked, I don't know, I maybe figured a way on my calendar to track it. Okay, I worked 20 days. Okay, if I only need to really work 19 days a month to make my $1 million mark, so I have that 1 day a month as a buffer, and then I would feel a little bit less guilty about taking those days off. So anyway, those are the thoughts for the day. Let me know what's working for you. If you want to learn more, go to podiatrypracticemastery.com. All this is on kind of like my podcast, and there's a couple of programs that I have on there. A lot of stuff for free, a couple of things if you want to join as a membership. Okay, thanks.